side effects. Let's say a drug has reached to the systemic circulation, right? And now we'll know how it will act on the cell. Let's say we have two sort of drugs. One is large molecular weight drug, these are large, and one is small molecular weight drug. This large molecular weight drug cannot go inside the cell, so it has to act via the surface receptor. For example, insulin, growth hormone, prolactin, and certain catecholamines like epinephrine and norepinephrine. These are large molecular weight substances need a surface receptor. On contrast, the steroids and vitamin D and thyroxine, these are very important. Everybody remembers steroid, estrogen, progesterone, aldosterone, testosterone, glucocorticoids. They go inside the cell because they are lipid soluble. Plus, vitamin D and thyroxine are very small molecular weight substance which can go inside the cell. So they act on receptors which are inside the cell. Once again, large molecular weight, surface receptor, small molecular weight, receptors inside the cell. Now we'll see how the drugs are acting on different sort of receptors and what category of drugs are they. Let's see if we have a drug which has high affinity. It binds to the receptor very strongly and stimulates the cell very strongly. These are called agonists. These are like new wives, binds strongly and stimulate the husband strongly. Now what about drug which binds to the cell very strongly but doesn't stimulate the cell? And at the top, this doesn't allow agonist to bind to the cell. So these are antagonists, binds to the cells very strongly, has affinity but does not stimulate the cell, and at the top it will keep agonist away. These are called antagonist drugs. And what about partial agonist? It binds with the intermediate affinity. It works and it stimulates with intermediate stimulation and doesn't allow agonist to bind. These are like girlfriends. This binds to the husband and slowly stimulates the husband, and at the top they will keep the wives away, right? So agonist, antagonist, and partial agonist. So a drug or agent which specifically binds to receptor and bring about their effects in the direct or indirect way, these are agonist. All the following have receptors which are transcription factors except, look, insulin, we said it is a sort of large molecular weight substance. It cannot go inside the cell. It has a surface receptor. These are all steroids and low molecular weight substance. All the following hormones have cell surface receptor except thyroxine and vitamin D as small molecular weight substance can go inside the cell. Ability of the body to eliminate drug is called clearance. And we'll be looking at one of the most important topic of the general pharmacology is ionization. What is ionization? Let me put it this way. Most of the drugs are either weak acid or weak base. That means the degree of ionization of that drug depends on two things. One is pH of environment and second being the pKa value of the drug. What is pKa value of the drug? It is the pH at which a drug is 50% ionized and 50% non-ionized. Now let's say you have a bunch of drugs. These are the ionized form of the drugs. These are the ionized form of the drugs. These ones are the non-ionized form of the drug. Ionized, that means either it has a negative charge or positive charge. These ionized drug cannot cross the biological membranes. And look, this non-ionized drug can cross the biological membranes and bring about the action. Now here is the takeaway message for you. Ionized drugs are water soluble but lipid insoluble. That means the ionized form of the drug can pass through the water. That means it can pass through your pee, the urine. The non-ionized form of the drug is lipid soluble and will be absorbed in your gut. That means ionized form will be cleared. Now let's look at this diagram very slowly. Here is the weak acid with its non-ionized form. Here is the weak acid with its ionized form, the weak base with its ionized form, and weak base with its non-ionized form. Now in what medium will you put weak acid so that it will remain in its non-ionized form? It will be acidic medium. If you put a weak acid in an acidic medium, it won't react. It will be in its non-ionized form. But if you put a weak acid in a base, it will be in ionized form because it will react with base. Similarly, if you put a base in an acid, look, it's acidic. If you put a base in a base, it's non-ionized. Can you name certain drugs which are weak acid? These are acetyl salicylic acid, barbituric acid. These are acid by its name. Penicillin, cephalosporin, loop diuretics, thiazides. These are weak acids. What are weak bases? Certain like local anesthetics, PCP, angel dust, amphetamines, morphine and atropine. Right? These are weak acids and weak bases. Phenobarbital, the most important one. So takeaway message for you: if you put an acidic drug in an acidic environment, it will remain non-ionized, because acid no reaction, non-ionized. It will be absorbed. Acid in base, ionized. Base in an acid, ionized. Base in a base, non-ionized. Clear? So here is a very beautiful question which asks that which of the following is true, right? And the answer is, if you put a phenobarbital with pKa value of 7.2, it is largely ionized at acidic pH. Phenobarbital is a weak acid, barbituric acid, and it will be only converted in its ionized form when you put it in a base, right? So acid in a base, it will be ionized, and this is wrong. It is largely non-ionized, right? Because if you put acid in an acid, it will be largely non-ionized. Now let's say your drug is in systemic circulation now, like warfarin. Warfarin is an oral anticoagulant drug, right? Now once it is in systemic circulation, it does not remain in free form. It binds with someone very special to him, right? That is plasma protein. It binds to plasma protein and gets inactivated, sleeps nicely. So the only free form of warfarin is active and can act as anticoagulant. Now if this plasma protein, beautiful plasma protein, finds someone very handsome than warfarin, it will bind to that boy and dump this warfarin, right? So example is sulfonamide. Once sulfonamide is in circulation, this sulfonamide will bind this plasma protein and replace warfarin. This is called displacement reaction. For example, patient is on warfarin therapy after myocardial infarction, and on next day if he develops infection and you give sulfonamide, this sulfonamide would replace warfarin and precipitate warfarin toxicity. Please don't give sulfonamide. This will precipitate warfarin toxicity. He will start bleeding. Now what's the main catch about this? That the binding side of warfarin and sulfonamide should be same. Then only displacement reaction will occur. Next is biotransformation reaction. To make it simple, let me just say that your goal is to make the drug more polar so that it can be excreted in urine, because polar things are water soluble. So there are two ways by which you can make a drug polar. Either you pull out a tongue, they pull out a compound from the drug which is more polar. That is, you pull out say a hydroxyl group which is exposed and make the drug more polar. Or you give this drug a hat like acetyl group which is more polar, right? Now if you are pulling out something from the drug, these are mediated by cytochrome enzymes, and these are called phase 1 biotransformation reaction. And now if you give something to a drug which makes it more polar, these are called phase 2 biotransformation reaction. Clear? Now this phase 1 biotransformation reaction, which are mediated by cytochrome enzymes, can be inhibited or induced. What do I mean by inhibited or induced? These are the list of drugs which can induce the cytochrome enzymes, and these are the list of drugs which can inhibit the cytochrome enzyme. For example, if you have a drug A which is present already in your body, and at the top you give phenytoin. Now this phenytoin will induce the cytochrome enzyme. That means it will increase the activity of cytochrome enzyme. Now once the increased activity of cytochrome enzyme is there, it will convert this drug into more polar, right? So the drug A will be eliminated very fastly. On the contrast, you give cimetidine. This cimetidine will inhibit cytochrome enzyme, and this drug A will be present as it is in your blood. It won't be excreted. So phenytoin as an inducer can hasten the elimination of other drug. Cimetidine as inhibitor can increase the toxicity of the other drug, right? So what are enzyme inducers? They are, just remember, Priyanka Chopra, I won't read this, Priyanka Chopra, barbiturate, rifampicin, and alcohol, right? Phenytoin and carbamazepine. These are enzyme inducer. It can reduce the half-life of other drug. What are enzyme inhibitors? Coke and P. Coke and P. Cimetidine, omeprazole, ketoconazole, erythromycin, and protease inhibitors. Protease inhibitors are a part of heart therapy, antiretroviral therapy, like indinavir or sakinavir, right? Now these acetylation reaction, which are phase 2 reaction, are mainly done in these drugs: SHIP, sulfonamides, hydralazine, isoniazid, and procainamide. These drugs are eliminated by acetylation reaction, which is a phase 2 biotransformation reaction, and are carried out in by acetylation. And these drugs can also precipitate systemic lupus erythematosus, a butterfly like rashes on the malar bones, right? The cheek rash. All of the following drug is cytochrome inhibitor. Coke 3, the Coke and P protease inhibitors: cimetidine, omeprazole, ketoconazole, and erythromycin. You have a friend of ketoconazole, itraconazole, right? So it is an inhibitor. Erythromycin. Protease inhibitors, ritonavir and sakinavir. Now both of them are in your list, right? Now you are in real trouble. It is given in the reference that sakinavir is less cytochrome inhibitor than all of the other protease inhibitors. So you got to remember this. The odd one out is sakinavir. Which is the cytochrome enzyme inhibitor? Again, the Coke P, ketoconazole, right? The inducer were PCBRA. All of the following are drugs causing SLE or SLE-like reaction except, you remember, SHIP, sulfonamide, hydralazine, isoniazid, and procainamide? Not penicillin. It doesn't cause SLE-like reaction. Next is therapeutic index, right? Now let's suppose on the x-axis you have dose, say 2 milligram and 10 milligram, and y-axis we record response in percentage, and in the graph you find curves, right? So you have dose, response, and curves. All the three words combine, and you also call this graph as dose response curve, right? Now let's suppose you have 100 patient, and this 100 patient you give 2 milligram of tablet and you mark the response. Out of this 100 patient, 50% of this patient develops a effect, right? We call this effective dose and 50% of population, and 2 milligram. That means in 2 milligram of dose, 50% of population has developed a therapeutic effect, also called effective dose on 50% of patient. Now once you give 10 milligram to each of this patient, 50% of the patient say develops a toxic effect of the drug. We call it toxic dose 50% of patient. That means this signifies that you have to give dose in this range only. This is the safe range. Don't go beyond this or don't go below this, right? This is the safety range. This is also called therapeutic index. So for this given drug, therapeutic index is 10 by 2. Toxic dose 10 and effective dose, that is 2. We get 5. That means if a normal therapeutic dose of a drug is 2 milligram, you could increase its dose up to 5 times. You cannot increase more than 5 times. Or in contrast, patient can take 5 more tablets of 2 milligram. He won't develop toxic effects, right? On the verge of developing toxic effect. So this drug is having pretty much wide therapeutic index, around 5. Now some drugs have very low therapeutic index, like this. For example, theophylline, cyclosporine, aminoglycoside, lithium, very low therapeutic index. Even little increase from standard allowed dose could precipitate its toxicity. So these drugs needs therapeutic drug monitoring. These drugs concentration have to be monitored in plasma, right? This requires therapeutic drug monitoring. On the contrast, certain drugs like antihypertensive, anticoagulants don't need therapeutic monitoring. Why? Do they have wide therapeutic index? No. The actual answer is that's because antihypertensive and anticoagulants, these drugs can be easily measured by its external effects. For example, if you give antihypertensive, you can record its response by measuring blood pressure. If you give anticoagulants, you could record its response by measuring prothrombin time, like say like warfarin. You don't need to go inside plasma and measure that drug. You could you could judge the level of drug by the response it is doing, right? So these don't need therapeutic drug monitor. When two drugs A and B are compared, false statement is 1 milligram has same effect than 1 milligram of drug A and drug B. That means both are equally efficacious. None is more efficacious than other. Therapeutic index is to assess safety of the drug. Narrow therapeutic index is seen with lithium, right? Drug with low therapeutic index whose blood levels need to be monitored. You need to monitor all of the drugs. These are aminoglycosides, cyclopurine, lithium, right? Anticoagulants can be monitored by measuring prothrombin time. You don't want to go inside plasma and measure how much amount of warfarin is present. You could easily just prick your finger and know the bleeding time or prothrombin time. ED50 is a measure of potency. What is potency? Potency is a relative term. Let's say you have drug A and B. A is given at 2 milligram and B is given at 10 milligram. Which one is more potent? If this both are developing same effect, then A is more potent than B. If both are producing same effect, that means if both have same efficacy, A is more potent than B. Category B drug in pregnancy. Now for pregnancy and teratogenicity, the drugs are classified according to different categories. For example, category A, B, C and D and X, right? Category A drugs are very safe, for example folic acid. Category B drugs are safe, for example penicillins and cephalosporins. Category C are they may be safe, that means some data reveal that it may be harmful, for example morphine. Category D and X, please don't use in pregnancy, for example thalidomide. Category D drugs can be used or not depending upon risk and benefit ratio. These are the list of anti-glaucomic drug. Dorzolamide, which is carbonic anhydrase inhibitor. Pilocarpine is cholinergic drug. Latanoprost is prostaglandin analog, and brimonidine is alpha 2 antagonist. Right now, this question wants to know which of the following will be the best to choose in pregnancy if a pregnant lady is having glaucoma, and the answer is brimonidine, which is a category B drug, and the data says it is the most safe drug to use in pregnancy as compared to all other anti-glaucomic drugs. Now let's say one fine day you want to become a huge boss of a pharmaceutical company. What are the things which you should take care of in drug designing? The foremost step of yours should be developing a drug based on its target. Your target should be very clear. For example, if you want to develop a drug against beta 2 receptor, first find a detailed structure of beta 2 receptor. So the best way to design a drug is target based designing, right? So once you know the target, you could also make a drug in such a way so that it can have a high affinity and selectivity for the target, right? Now once say you have structured that a drug, you have to send it for the clinical trials, right? So trials include preclinical trial and different phases of clinical trials. So first you have to test that drug in an animal and check whether the response is seen or not. Then you have to send it to phase 1 clinical trial, and these are done in healthy volunteers. say 50 healthy volunteers. And what do you know from phase 1 clinical trial is the safety and the dosage which is required for the drug or maximum tolerated drug. Now there are different companies which are carrying out phase 1 clinical trials, and actually they give money to the volunteers who come and give their body for testing, right? Please don't go. What if the answer comes drug is not safe? You are in trouble, man. Phase 1 clinical trials, safety and dosage, maximum tolerated drug, right? Safety and dosage. Now if drug is passed in phase 1, it is sent to phase 2 clinical trial for efficacy, right? Its effectivity in the patients. So phase 2 is the first landmark where the drug is tried for the first time in patients, and this is the phase where most of the drug fail, because drug may effect in animal, may show effect in, say, may show positive findings that yeah, it is safe and it has a good dosage in healthy volunteers, but it shows no efficacy in patient, no use. Most of the drug fails in phase 2. Now if it shows efficacy in patient, it is sent to phase 3 trial for further confirmation of its effectiveness and common side effect. Now here is where it is compared with the old drug, and it is said that which of the following is better. So right, so phase 3 is for comparison with the previous drug. Now if it passes the phase 3, it is sent to phase 4 for post marketing surveillance, right, and to find common and rare side effects, right? Now which body actually does adverse drug reaction monitoring? That is by pharmacovigilance, right? Here is the ADR monitoring centers are there. Now what things take care of adverse drug reaction? These are actually the ADR monitoring centers. This is present at Sweden, right? This is called pharmacovigilance, that means to monitor the adverse drug reaction. So the preferred method of drug designing is target based, right? And for the drug designing, one of the concern is you want to increase the interaction with the target protein. Because the following trial can be performed to determine the maximum tolerated drug. We say it is phase 1, right? If you want to know the usefulness in control condition, it is called efficacy. Pharmacovigilance is for drug safety, the adverse drug reaction monitoring. Phase 2, you assess the efficacy of the drug. In phase 3, you compare the drug with the previous one, right? The value of a new drug related to old drug in phase 3. And this is the question: orphan drugs are, your key says, the answer key says drugs that are used very rarely, but according to KD Tripathi, it is actually the drugs which are used for treating rare disease. And obviously if the disease is rare, you'll use that drug very rarely, right? These are called orphan drugs.